Hey everyone, and welcome back for another deep dive. Today we are jumping headfirst into the world of ENT conditions.
ENT, ear, nose, and throat.
Yeah, exactly.
And we can even go a bit further.
Even further, all the way down to the esophagus.
That's right.
You know, those listeners out there are so hungry for information about these medical conditions.
I bet they are.
And we've got some seriously interesting things to share, I think.
Oh, absolutely. I'm ready to dive in.
So let's get to it. We've got tons of research, medical insights, and expert opinions to sift through. And to make sure everyone listening feels like an ENT pro, by the end of this, we'll be covering the causes,
The symptoms.
and the treatments for each of these conditions.
Okay, great.
Now let's start with conductive hearing loss. What's the deal with that?
Well, you have to picture sound waves. They're like on a journey, right? They're trying to get to your brain.
Okay.
And to do that, they got to travel a specific path through the outer ear, then the middle ear, and finally the inner ear, where they transform into signals that your brain can actually understand.
I see.
Now, conductive hearing loss, that's like setting up a roadblock on that pathway.
A roadblock.
Yeah, something's obstructing those sound waves.
Got it. And where's the usual traffic jam happening?
Mostly in the outer ear or the middle ear.
Makes sense. So what kind of things are causing these blockages? I mean, we've got everything from earwax buildup to more serious things like otosclerosis mentioned in the research.
Right.
And it really emphasizes getting a good examination and using tuning fork tests to pinpoint what's really going on.
Those tuning fork tests, super clever and pretty simple, really.
Yeah.
It's a clever way to sort out the different kinds of hearing loss.
Okay.
You see, by comparing how someone hears the vibrations, first when the tuning fork is held near the ear, and then on the bone behind the ear, it's like a little trick we can figure out if the problem is in that sound conduction pathway. You know, that's the hallmark of conductive hearing loss. Or if the issue is actually in the inner ear or the nerve itself.
Right, which would be sensorineural hearing loss.
Exactly.
Okay. So we've talked about blocked pathways, but now we're moving on to cholestoma, and that's when things get a bit more serious.
It does sound a bit more intense.
Yeah, it's described as an abnormal growth of skin cells happening right in the middle ear.
Right in the middle ear.
And apparently it can do some real damage.
Definitely something that needs attention, for sure.
Yeah, what's concerning is that as this cholestoma grows, it can start to erode the tiny bones in the middle ear.
Those ossicles, incredibly delicate.
Yeah, those are the ones responsible for transmitting those sound vibrations.
Exactly.
So that can lead to hearing loss, dizziness, and get this, even facial nerve paralysis in some cases.
In the most severe cases.
Yikes. That's definitely not something you want to mess around with. Now, I'm seeing in our notes that there are two main types of cholesteatomas congenital.
And acquired.
So what's the difference?
Well, it all comes down to how they develop.
Okay.
You see, a congenital cholesteatoma, that's present right from birth. And it tends to be a bit less aggressive. Now, an acquired cholesteatoma, that usually pops up later in life.
Oh, I see.
Often it's a complication from chronic ear infections. And those can really cause some damage.
So early detection is key, right? If you're having constant ear discharge or you're noticing some hearing loss or your ear just feels full all the time, you better get that checked out.
Absolutely.
Now, this is where it gets really interesting and maybe a bit scary for some surgery. It seems like that's often the best way to deal with a cholesteatoma.
Often it is.
You know, get rid of it completely and prevent any more issues.
Absolutely. The goal is to completely get rid of that cholesteatoma, rebuild any damaged parts of the middle ear, really restore things back to normal.
Yeah, prevent infections from coming back.
You got it. And thankfully, these procedures, they've come a long way. Surgeons can achieve amazing results these days.
That's reassuring. Now, two specific surgical procedures are mentioned: mastoidectomy and tympanoplasty. So, from what I'm reading, a mastoidectomy involves removing infected parts of the mastoid bone,
Yeah.
the one behind the ear,
Right behind the ear.
and tympanoplasty that's focused on reconstructing the eardrum and those tiny ossicles.
Those tiny bones.
Yeah, the ones we talked about earlier.
Exactly. Amazing procedures.
Yeah.
Now, while we're on the topic of chronic ear problems, let's talk about chronic suppurative otitis media, or CSOM. Yeah. This is a long-term infection of the middle ear that just won't quit.
It can be pretty stubborn.
Very stubborn.
Now, one thing that really stands out in our research is the distinction between wet and dry perforations in the eardrum.
Yes.
So a wet perforation, that means there's active discharge coming from the ear.
That's right.
And dry means there's a hole, but no active infection at that moment.
Correct.
Okay, so what does that mean for treatment?
Well, it definitely changes things.
Okay.
With wet perforations, the first thing is meticulous cleaning. It's called oral toilet.
Oral toilet.
Yeah. It's essential. And then, of course, antibiotic ear drops to fight that infection head on.
Okay, so oral toilet and antibiotics for wet perforations. What about dry perforations?
For those, surgery is often the way to go. Specifically, a tympanoplasty to repair the eardrum and prevent any future infections.
So, two different approaches based on whether the perforation is actively infected or not. It seems like with CIAMA, patient education and follow-up care are super important, given that it can recur.
They are super important.
Okay, now let's shift gears a bit and talk about facial nerve paralysis. It's a little unnerving to think about losing control of your facial muscles.
It can be.
It can be. And our sources really highlight the facial nerve's journey, starting in the brain, traveling through the skull, specifically the temporal bone, and then branching out to control all those muscles that give us our facial expressions.
Fascinating journey.
It is. And it seems like the most common culprit behind facial nerve paralysis is Bell's palsy.
Bell's palsy, that's right.
Now, Bell's palsy can hit pretty suddenly, right? Someone could wake up one morning and half their face is just drooping.
That's right.
Affecting their smile, their ability to close their eye, maybe even how clearly they can speak.
All of that. And it can happen overnight.
Wow. So what's the deal with Bell's palsy? What causes it?
Well, the exact cause of Bell's palsy is still a bit of a mystery.
Oh, really?
But most experts think it involves inflammation of the facial nerve, probably triggered by some kind of viral infection.
So the nerve gets inflamed and it's like it's temporarily out of commission.
Exactly, like it's been put on hold.
Yeah.
And that's what causes all those symptoms, the drooping, the trouble closing the eye, even drooling sometimes.
Now, that doesn't sound fun.
No, it doesn't.
But the good news is, our sources say most people with Bell's palsy recover completely,
Yes, they do.
often within a few weeks or months.
And steroids seem to be the key player in helping to reduce that inflammation and speed up recovery.
So starting treatment with steroids early can really make a difference.
It can make a big difference in the chances of a full recovery.
Okay, let's shift gears again, this time to something that can be incredibly disorienting. Vertigo.
Vertigo.
Yeah. And this isn't just your everyday dizziness.
Not at all.
This is that feeling that the world is spinning around you,
The
right?
room is spinning.
Yeah.
Exactly.
And according to our research, the most common cause is benign paroxysmal positional vertigo.
BPPV.
Yeah, BPPV.
Got it.
It's a mouthful.
It is.
So what causes that specific type of vertigo?
It all boils down to these tiny crystals in your inner ear. They're called otoliths.
Otoliths.
Yeah.
Okay.
Now, these crystals are usually embedded in a gel-like substance.
Okay.
And their job, they help your brain figure out where your head is in space.
Like a built-in level.
Exactly. That's a great way to put it.
Yeah.
But in BPPV, something goes wrong. These otoliths get dislodged, and they end up in these semicircular canals.
Semicircular canals.
Yeah.
Those are in the inner ear, too.
They are. They're those fluid-filled tubes, and they're responsible for balance.
So these crystals end up where they shouldn't be.
Exactly. And when they move around in there, they send confusing signals to the brain. And that's what causes that spinning sensation.
So it's like having a tiny earthquake inside your ear.
Yes, that's a great way to describe it.
I can see how that would mess with your balance. And the source material mentions that certain head movements can actually trigger BPPV.
That's right, specific head movements.
Yeah, and then there are these repositioning maneuvers that can help guide those crystals back to where they belong.
They can. It's amazing, really.
It is. So a healthcare provider can guide someone through these specific head movements,
Precise head movements.
and it essentially resets the balance system.
It's like a gentle reset.
That's incredible. Now let's move on to a condition that can lead to progressive hearing loss. Otosclerosis.
Otosclerosis.
Okay. Now, if I'm getting this right, otosclerosis involves abnormal bone growth in the middle ear, specifically affecting the stapes.
That's right.
And the stapes is one of those tiny bones responsible for transmitting sound vibrations from the middle ear to the inner ear.
It is.
And it's a crucial one for sound transmission. So when the stapes isn't working properly, it disrupts that pathway, leading to hearing loss.
Exactly. That's exactly what happens.
Now, here's a fascinating thing mentioned in the sources. Paracusis willisi. Have you heard of this?
Paracusis willisi.
Yeah.
It's fascinating, isn't it?
It is. It's this phenomenon where people with otosclerosis actually hear better in noisy environments.
It seems counterintuitive, right?
It does. So why would that be?
Well, it's thought to be because in noisy environments, people tend to speak louder naturally.
Right, to be heard over the noise.
Exactly. And that increased volume actually helps to overcome the conductive hearing loss caused by the stiff stapes bone.
So it's like the background noise is leveling the playing field.
That's a great way to put it. It's as if the background noise is helping those sound waves reach the inner ear more effectively.
Wow, that's incredible. And this phenomenon was actually recognized centuries ago, long before we had any real understanding of how the ear worked.
I know, it's amazing.
The body just finds a way to adapt, even with these challenges.
It's fascinating how the body works.
It really is.
Yeah.
So how is otosclerosis typically treated?
Well, treatment often involves a surgical procedure
Okay.
called a stapedectomy or stapedotomy.
Stapedectomy. Those sound familiar.
They might.
From what I'm reading, during a stapedectomy, the surgeon removes the affected stapes bone and replaces it with a prosthesis, tiny artificial bone,
Tiny little artificial bone.
to restore that sound transmission pathway.
Exactly. It's a delicate procedure, but for many people, it can dramatically improve their hearing.
That's great. Okay, let's move on to a very common ear problem that I think most of us have experienced at some point, otitis externa, more commonly known as swimmer's ear.
Swimmer's ear.
Yeah, swimmer's ear. I know I've had it before. It's an infection of the outer ear canal, and let me tell you, it can be painful and itchy.
It can be really uncomfortable.
So what causes swimmer's ear?
It's often triggered by water getting trapped in the ear canal, creating a moist environment.
Right.
Perfect breeding ground for bacteria and fungi.
Oh, that makes sense. So if your ear feels painful, itchy, or if you see any redness or discharge, you probably have swimmer's ear.
Probably.
Now, our sources describe the typical symptoms, but they also mention that in some cases, otitis externa can progress to something called malignant otitis externa.
Malignant otitis externa, yeah.
And that's where things get more serious.
Much more serious. That's because it starts to affect the deeper tissues in the ear canal, even the bone.
The bone. Wow. So what makes it malignant?
Well, it tends to happen in people who have weakened immune systems.
Okay.
People with diabetes, for example. Their bodies just can't fight off the infection as effectively.
That's scary. So how's typical otitis externa treated? And what about the malignant kind?
For the typical swimmer's ear, usually antibiotic eardrops are enough to knock out that infection. But for malignant otitis externa, you need a much more aggressive approach. Often that means intravenous antibiotics. You need to reach those deeper tissues to fight off the infection effectively.
It's amazing how something like an ear infection can range from a minor annoyance to a serious health concern.
It is.
Now, let's shift gears to some of the diagnostic tools used to assess different ear conditions.
Okay.
Our sources talk about tympanometry,
Tympanometry.
and I'm guessing that has something to do with the eardrum.
You guess right.
Okay, so what is it?
Tympanometry is a quick, painless test that measures how your eardrum moves in response to changes in air pressure.
So it's like gently puffing air into your ear to see how flexible your eardrum is.
You got it.
What kind of information does that give you?
Well, it can tell us if there's fluid in the middle ear, which is common with ear infections. It can also detect if the eardrum is stiff or if there's a perforation, a hole in the eardrum.
That makes sense. Another tool mentioned in our research is the tuning fork test, which we touched on earlier when talking about different types of hearing loss.
A classic test.
It is.
Still so relevant today.
Yeah, and it can help us distinguish between conductive hearing loss,
Where the problem is in the sound conduction pathway.
right, and sensorineural hearing loss, where the inner ear or the auditory nerve is affected.
Exactly.
And the way you hear the sound of that vibrating tuning fork, whether it's louder near your ear or on the bone behind your ear, that helps to pinpoint the location of the problem.
Precisely.
It's amazing how simple tools can be so insightful.
They can.
Okay, let's talk about a type of hearing loss that is often associated with aging. Presbycusis. It's a natural part of getting older,
A natural part.
but it can have a big impact on someone's quality of life.
It can.
So, presbycusis, how common is it?
It's incredibly common.
Really?
It's estimated that it affects about half of all people over the age of 75.
Wow. So what's actually happening in the ear as we age?
Well, the inner ear gradually changes over time.
Okay.
It makes it harder to hear certain sounds. And it's not just one thing going wrong either.
Right. I'm seeing in our notes that there are actually 4 different types of presbycusis.
Yeah.
Each one involves specific areas of the inner ear, the sensory cells, the nerve fibers, the blood supply, or even the mechanics of the inner ear itself.
They can be complex.
It can be. And our sources really emphasize the importance of patient education and realistic expectations when it comes to presbycusis.
Very important.
It seems like hearing aids can play a big role in helping people manage this condition.
Absolutely. They can significantly improve hearing for people with presbycusis. They amplify sounds, making it easier to hear conversations, environmental noises, music. The key is to get a proper assessment and make sure the hearing aids are custom fitted to the individual's needs.
That makes a lot of sense. Now let's talk about a more serious complication that can arise from middle ear infections: acute mastoiditis. This involves the spread of infection to the mastoid bone, which, as we've discussed, is located right behind the ear.
Acute mastoiditis. Definitely a condition that needs prompt attention.
It does?
It can have serious consequences.
Really?
The infection can spread beyond the mastoid bone, potentially leading to complications like hearing loss,
Oh, wow.
facial nerve paralysis,
Gosh.
or even more serious issues like meningitis.
That's scary stuff. So early diagnosis and treatment are essential, right?
Absolutely essential to prevent those complications.
Okay, so what are the warning signs? What should people look out for?
Well, the hallmark symptom is pain and swelling behind the ear, often with a fever and redness.
Okay.
Sometimes the ear might even stick out because of the swelling.
Oh, wow. And what about treatment?
Early treatment with antibiotics is crucial, and in some cases, surgery may be necessary to drain the infection.
Okay, so that's acute mastoiditis. Now let's talk about another serious complication: lateral sinus thrombosis.
Lateral sinus thrombosis.
This is a blood clot
A blood clot.
that forms in one of the major veins that drains blood from the brain.
That's right, the lateral sinus.
And this can also be triggered by an ear infection.
It can.
So if the infection spreads to the lateral sinus, it causes inflammation, which then leads to a blood clot.
A dangerous blood clot.
Yeah, that sounds really dangerous.
It is. The key is to catch it early.
So what are the symptoms we should be looking out for?
Think high fever, chills, a severe headache, even seizures in some cases.
Oh, wow, those are some serious red flags.
They are. You need prompt treatment with antibiotics, sometimes blood thinners,
Okay.
to prevent that clot from spreading and causing even more serious issues like a stroke or a brain abscess.
Brain abscess.
Yeah.
Okay, that brings us to another potential complication: brain abscesses.
Brain abscesses.
It's a little frightening to think about,
But it is.
but it's important to be aware of the possibility.
It is.
Our sources describe the 4 stages of abscess development,
4 stages.
starting with that initial invasion of bacteria and eventually culminating in this pus-filled cavity in the brain.
A pus-filled cavity.
So brain abscesses are a medical emergency.
They are.
We need to recognize those symptoms early on.
We do.
What are some of those symptoms?
Well, they can be subtle at first, things like a headache, fever, fatigue. But as the abscess grows, those symptoms intensify.
Okay.
You might see seizures, weakness, changes in mental status. Prompt treatment with antibiotics is absolutely essential.
Okay.
And often, surgery is needed to drain the abscess.
So an ear infection, if not treated properly, can have really far-reaching consequences.
It can.
Okay, let's dive into a condition that involves increased pressure in the brain: otitic hydrocephalus.
Otitic hydrocephalus.
What's going on in this condition?
Well, it's a bit complex, but basically there's a buildup of cerebrospinal fluid in the brain.
Cerebrospinal fluid.
Yeah, and this can be triggered by a middle ear infection.
A middle ear infection.
We don't fully understand why this happens, but it's thought to involve a combination of inflammation, blood clots, and impaired fluid absorption.
So the infection throws the fluid balance in the brain out of whack.
Exactly.
What are some of the signs to look out for with this one?
Well, the classic symptoms of increased pressure in the brain are a headache, vomiting, and changes in vision.
Okay, so if any of those symptoms develop,
Yeah.
it's crucial to get medical attention immediately.
Crucial.
Okay.
Right away. Now let's move on to something more mechanical, a traumatic tympanic membrane perforation.
Traumatic tympanic membrane perforation.
Or, in simpler terms, a ruptured eardrum.
Ah, ruptured eardrum.
These can be pretty painful, and they often cause temporary hearing loss.
Okay, so what causes a ruptured eardrum?
All sorts of things, really.
Oh.
A direct blow to the ear.
Okay.
A sudden change in pressure, like during a loud explosion or while flying.
Right.
Even an ear infection can sometimes cause the eardrum to rupture.
Wow, so a lot of different things. And do most eardrum perforations heal on their own?
Most do, especially if they're small.
Okay.
But if the perforation is large or if it doesn't heal properly, then a surgical repair might be needed.
Okay, good to know. Now, our sources mention that it's important to document any hearing loss that comes with a ruptured eardrum using audiometry.
Audiometry, that's right.
We'll get to that in a bit. But first, let's talk about sensorineural hearing loss, which stems from problems in the inner ear or the auditory nerve.
Sensorineural hearing loss.
Yeah,
It's complex.
it is.
It can be caused by so many things.
It can. From aging to loud noises,
Right.
medical conditions, genetics can even play a role. It seems like identifying the specific cause is really important for figuring out how to treat it.
Identifying the cause is crucial. I think of it like detective work sometimes.
Right, like medical detective work. And I see in our sources that genetic testing, imaging studies, and other specialized tests can help pinpoint the underlying cause of sensorineural hearing loss.
They can. It can be quite a journey to figure out the full picture.
Yeah.
Now, let's talk about a condition that involves a viral infection, Ramsay-Hunt syndrome.
Ramsay-Hunt syndrome. Okay.
Yeah.
What exactly is that?
Well, it's caused by the reactivation of the varicella-zoster virus.
Okay.
It's the same virus that causes chickenpox and shingles.
Oh, wow. So how is Ramsay-Hunt syndrome different?
Well, in Ramsay-Hunt syndrome, this virus affects the facial nerve,
The facial nerve. Okay.
leading to a pretty distinctive combination of symptoms.
I'm seeing in our notes that it involves a painful rash in or around the ear, along with facial paralysis.
Yes, a painful rash and facial paralysis, and it can be quite debilitating,
That doesn't sound pleasant at all.
No, it doesn't. In addition to the rash and the facial paralysis, it can also cause hearing loss, dizziness, and even tinnitus, that ringing or buzzing in the ears.
Oh, wow. So what's the treatment for Ramsay-Hunt syndrome?
Prompt treatment with antiviral medications and steroids is essential. That's really the key to reducing the severity of the symptoms and improving the chances of a full recovery.
So another one where early intervention is crucial.
It is.
Now, let's move on to perichondritis, a bacterial infection that affects the cartilage of the outer ear.
Perichondritis.
And this one can be quite painful, right?
Yes, it can. It involves inflammation of the perichondrium. That's the tissue that surrounds and nourishes the cartilage.
Okay. And what causes perichondritis?
It's often triggered by trauma to the ear,
Like a piercing.
a piercing, an injury,
Okay.
but it can also be caused by infections spreading from the surrounding skin.
So what should people look out for?
The main symptom is a painful, red, swollen outer ear.
Okay, so if you see that, you'd better get to a doctor quickly.
Prompt treatment is essential.
Yeah, our sources stress the importance of prompt treatment to prevent complications.
You need to stop that infection from damaging the cartilage.
Yeah, I'm reading here that in severe cases, it can actually destroy the cartilage.
It can, and that can lead to deformities of the ear.
That's definitely something you'd want to avoid. Now let's dive into the anatomy of the middle ear a bit.
Okay.
We've talked about conditions that affect this area, but it's helpful to get a clear picture of the structures involved.
It's a remarkable piece of engineering, the middle ear.
It is.
It's a small, air-filled space, but it's critical for our hearing.
Okay, so break it down for me. What are the key players in there?
Well, we have the eardrum, which vibrates in response to sound waves. And then we have the ossicles.
The osseous.
Those are the three tiny bones, the malleus, imparfus, and stapes. They form a chain connecting the eardrum to the inner ear.
We've talked about those ossicles a few times already, but it's still amazing to me how such tiny bones can have such a big impact on our hearing. How do they actually amplify sound?
It's a combination of factors.
Yep.
First, the eardrum itself, its shape and position, helps collect and concentrate sound waves onto the malleus. That's the first of the ossicles.
Okay.
Then, those ossicles act like a lever system, amplifying the vibrations as they pass from the malleus to the incus and then to the stapes.
Okay.
Finally, the stapes transmits those amplified vibrations to the oval window. That's a membrane-covered opening in the inner ear. It's like a chain reaction, with each step boosting the power of the sound signal.
That's incredible. It's like a tiny symphony happening inside our ears. Now let's talk about the eustachian tube. I think we've all experienced that popping sensation in our ears when we change altitude, on a plane or driving up a mountain.
Right, the eustachian tube.
Yeah, that's the eustachian tube at work, right?
It is.
So tell me about it. What does it do?
Well, the eustachian tube connects the middle ear to the back of your throat.
Okay.
Its main job is to keep the pressure balance between the middle ear and the outside environment.
Okay.
When the pressure changes quickly, like during takeoff or landing in a plane, you need to swallow or yawn to open up that eustachian tube and let the pressure equalize.
Okay.
Otherwise, you get that uncomfortable feeling of pressure in your ears.
It's like a pressure valve for the ears. But it seems like the eustachian tube can also be a source of trouble.
It can be.
Our sources mention that blockages in the eustachian tube can lead to problems like middle ear infections. Why is that?
Well, think about it this way. When the eustachian tube is working properly, it opens briefly when we swallow or yawn. Host. It allows air to flow in and out, keeps things balanced.
Right.
But when it gets blocked, could be mucus, inflammation, even anatomical variations. Air can't circulate properly, pressure builds up.
Oh, I see.
And that creates a perfect environment for bacteria or viruses to multiply. Boom! Infection.
It's like a closed-off room where germs can throw a party.
Exactly.
Okay, now let's talk about two surgical procedures that involve the middle ear. Tympanoplasty and ossiculoplasty.
Tympanoplasty and ossiculoplasty.
Yeah, these are often used to address damage or dysfunction in the middle ear.
That's right.
So tympanoplasty is the surgical repair of the eardrum.
The eardrum.
Yeah, often performed when there's a perforation or a retraction that's affecting hearing.
Makes sense.
And ossiculoplasty focuses on reconstructing the ossicular chain,
The ossicular chain.
those tiny bones
Those tiny bones.
that transmit sound vibrations.
Exactly.
So these sound like pretty intricate procedures.
They can be.
From what I'm reading, they involve using tiny grafts and prostheses to restore these delicate structures of the middle ear.
They do. The goals of these surgeries are to improve hearing, prevent those infections from coming back, and essentially restore the middle ear's natural anatomy and function.
It's amazing what surgeons can accomplish with such tiny instruments.
It is amazing.
Now, let's zero in on the eardrum itself, also known as the tympanic membrane.
The tympanic membrane.
Our sources highlight its unique structure and function, dividing it into two main parts, the pars tensa and the pars flaccida. Can you explain the difference?
Sure. The pars tensa is the larger, tighter portion of the eardrum.
Okay,
It's responsible for most of the vibration transmission.
so it's like the main drum head.
Exactly, stretched tight to pick up those sound waves.
Wow.
The pars flaccida is the smaller, looser portion at the top of the eardrum.
Okay.
It's more flexible, doesn't vibrate as much.
And I'm seeing in our notes that the pars flaccida is more prone to problems like retractions, which can contribute to cholesteatomas,
That's right.
those skin cell collections we discussed earlier.
Exactly.
Why is that? Why is the pars flaccida more prone to retractions?
Well, because it's looser, it's more likely to get pulled inward, creating a pocket.
Oh, I see.
And that's where those skin cells can accumulate and form a cholesteatoma.
Okay, that makes sense. Now, another interesting feature of the eardrum is the cone of light.
The cone of light.
Yeah, it's a key landmark used during ear examinations.
It is.
I remember seeing that when I had my ears checked.
Right.
What does it tell us about the eardrum?
Well, the cone of light is a reflection of light from the otoscope, the instrument doctors use to examine the ear.
Okay.
Its position and shape can give clues about the health and integrity of the eardrum. If it's distorted or absent, it could be a sign of fluid in the middle ear or a problem with the eardrum itself.
It's like a built-in health indicator for your eardrum.
You could say that. Now, let's shift our focus from hearing to balance.
Okay, balance.
Let's talk about the amazing system that helps us stay upright and steady. The inner ear plays a key role here, working with our vision and proprioception, our sense of body position.
It's remarkable how different systems in the body work together seamlessly.
It is. So the inner ear, specifically the vestibular system, provides information about our head's position and movement in space.
Okay.
Our eyes provide visual cues about our surroundings.
Right.
And proprioceptors in our muscles and joints tell us about the position of our limbs.
It's like a three-way communication system, constantly sending updates to our brain to keep us balanced.
A three-way communication system, that's a great way to put it. But what happens when there's a disruption in one of these systems?
Yeah, what happens then?
Well, that's when you get dizziness, imbalance, even vertigo, that spinning sensation.
To assess how this balance system is working, our sources describe a test called the caloric test.
The caloric test.
Yeah, how does that work?
It involves irrigating the ear with warm and cool water.
Okay.
This stimulates the inner ear, specifically the vestibular system, triggering eye movements called nystagmus.
So you're pouring water into the ear, and you're looking for specific eye movements.
That's right. By observing the direction and duration of those eye movements, we can get a sense of how well the vestibular system is functioning on each side.
Okay.
It helps us identify if there's a weakness or an imbalance.
Okay, that makes sense. Now let's talk about hearing aids. An important tool for people with hearing loss.
Hearing aids, yes.
They come in all sorts of styles, from those that sit behind the ear to those that fit right inside the ear canal.
A variety of styles.
So how do they work, and what are the key things to consider when choosing hearing aids?
Well, at their core, hearing aids are basically mini amplifiers.
Okay.
They help boost sound signals so they're easier to hear. They have a microphone that picks up the sound waves, an amplifier to increase the volume of those signals, and a speaker to deliver the amplified sound to the ear.
So it's like a personalized sound system for your ears.
Exactly.
And our sources emphasize that finding the right type of hearing aid is crucial.
It is crucial.
It's not one size fits all.
Not at all.
And they stress the importance of personalized fitting and patient education.
Very important. The best hearing aid for one person might not be the best for another. It depends on the type and severity of their hearing loss, the shape of their ear canal, even their lifestyle, how active they are. It's crucial to work with an audiologist who can assess their individual needs and recommend the most appropriate device.
That makes sense. Now, what about those bone-anchored hearing aids, BA-Hays?
B.A. Hayes.
I've heard of those, but I'm not entirely sure how they differ from traditional hearing aids.
Well, B.A. Hayes are a unique type of hearing aid that's surgically implanted into the bone behind the ear.
Implanted into the bone.
Yes. And they're a great option for people who can't wear traditional hearing aids. Maybe they have chronic ear infections or malformations of the outer ear.
Okay, so instead of amplifying sound through the air, like regular hearing aids do, BA-Hays transmit those sound vibrations directly to the inner ear through the bone.
Exactly.
That's pretty cool.
It bypasses the outer and middle ear completely. It directly stimulates the cochlea, the hearing portion of the inner ear.
Okay, let's talk about a condition that can be incredibly frustrating, tinnitus.
Tinnitus.
That perception of sound when there's actually no external source.
That ringing, buzzing, hissing, roaring in the ears.
Yeah, and it can be constant or intermittent,
It can be.
and range in volume.
From a soft whisper to a loud roar.
Wow. So what causes tinnitus?
There are many potential causes.
Okay.
Ear problems like hearing loss,
Okay.
neurological conditions, cardiovascular issues, even medications can sometimes trigger tinnitus. It can be a real challenge to pinpoint the underlying cause.
It's like medical detective work again.
Exactly. The first step is to try to identify any underlying cause that we can treat.
Okay.
But unfortunately, in many cases, the cause remains a mystery.
So what can you do for people who are struggling with tinnitus, especially if the cause is unknown?
Well, there's no one-size-fits-all solution,
Okay.
but there are strategies that can help. Reassurance is important. Tinnitus, while annoying, is usually not a sign of a serious medical problem.
Okay, that's reassuring.
Stress management is also important because stress can make tinnitus worse.
Okay, I've also heard of sound therapy being used. How does that work?
Sound therapy uses external sounds, things like white noise or nature sounds, to mask the tinnitus, make it less noticeable.
So it's like creating a distraction.
In a way, yes.
Okay.
It helps people habituate to the tinnitus, essentially training their brains to tune it out.
That makes sense. Okay, shifting gears now. Let's talk about the importance of early detection, specifically with hearing screening in newborns. Catching hearing loss early is crucial so you can put interventions in place to support language development and communication.
Absolutely. Newborn hearing screening is so important.
It is.
It's standard practice now in many countries.
Yeah, and it's a quick and painless procedure, right?
It is.
With the potential to make a huge difference in a child's life. So what kind of techniques are used?
Well, the two main techniques are otoacoustic emissions, or OAEs, and auditory brainstem response, or ABR.
Okay, OAEs and ABR, so seeing those in our notes. So OAEs are those tiny sounds that the inner ear produces in response to sound stimulation.
That's right.
And ABR involves placing electrodes on the baby's head to measure brainwave activity in response to sounds.
Exactly.
It's amazing how we can assess hearing even in newborns.
It is. These tests are incredibly valuable, you know? They let us identify hearing loss early on, opening the door for early interventions that can help maximize a child's hearing potential and support their development.
Absolutely. Now, for individuals with severe to profound hearing loss who don't benefit from hearing aids, there's another incredible option: cochlear implants.
Cochlear implants are game changers. They bypass the damaged inner ear and directly stimulate the auditory nerve with electrical signals.
Wow.
It's amazing. They're providing a sense of sound to individuals who would otherwise be profoundly deaf.
That's mind-blowing. And our sources really highlight the importance of a multidisciplinary approach when it comes to cochlear implantation.
It is multidisciplinary.
Involving surgeons, audiologists, speech therapists, educators. It's a whole team effort.
Absolutely, a team effort to maximize the benefits. It's not just about the surgery itself.
Right.
It's about providing the individual with the support they need to learn how to interpret those new sounds and develop language skills.
Okay, let's talk about a condition that causes sudden and severe vertigo. Vestibular neuronitis. What's happening in this one?
Vestibular neuronitis. It's thought to be caused by a viral infection that affects the vestibular nerve, which, as we've discussed, is a key player in our balance system.
Okay.
It usually hits suddenly, causing intense vertigo, nausea, vomiting, and difficulty with balance.
That sounds absolutely awful.
Yeah.
But thankfully, it's often self-limiting, right?
It is, thankfully.
Meaning it resolves on its own with time.
Most individuals recover fully within a few weeks. The focus of treatment is really on managing those acute symptoms, often with medications to relieve the nausea and dizziness.
So it's about riding it out until the body heals itself. Now, let's talk about a rare but serious complication of mastoiditis. Bisolds abscess.
Bisolds abscess.
Okay, what is that?
Well, it's a collection of pus that forms deep in the neck,
Deep in the neck, okay.
beneath the sternomastoid muscle,
Okay.
and it happens as a result of the infection spreading from the mastoid bone.
It sounds like prompt medical attention is crucial here. What kind of treatment is typically needed?
Intravenous antibiotics are usually the first line of defense.
Okay.
And sometimes surgery is needed to drain the pus and prevent the infection from spreading further.
Okay, that's a reminder that these ear infections can be a lot more serious than they seem.
They can.
Okay, shifting gears a bit, let's delve into the world of oral conditions, starting with oral submucous fibrosis, or OSFs. It's a condition that affects the tissues in the mouth, making it hard to fully open the mouth.
It does. OSF is a chronic condition where the tissues inside the mouth, the cheeks, the palate become inflamed and progressively scarred.
Okay.
This scarring makes the tissue stiff, inflexible, leading to difficulty opening the mouth wide, speaking, even eating.
That sounds incredibly uncomfortable and limiting.
It is.
And I'm seeing in our sources that OSF is strongly linked to chewing areca nuts or betel quid, which are common in some parts of Asia.
You're right. Those substances contain chemicals that are very irritating to the mouth. Chronic use leads to inflammation and eventually fibrosis scarring of those tissues.
It's a stark reminder that seemingly harmless habits can have really serious long-term consequences. And it sounds like OSF is not something to take lightly. Our sources describe it as a precancerous condition, meaning there's a risk it could develop into oral cancer.
Early detection and intervention are key here.
They are. So if someone's experiencing burning in the mouth, pain, or they're finding it increasingly difficult to open their mouth, they should seek medical attention.
As soon as possible.
What are the treatment options for OSF?
Well, the goal is to slow or stop the progression of that fibrosis. Manage symptoms to improve quality of life. Lifestyle changes are essential, stopping the use of those areca nuts or betel quid. That's crucial.
Okay.
Some medications like corticosteroids can help reduce inflammation, but they're not always effective. In severe cases, surgery might be needed to release the scarred tissues, improve mouth opening.
Okay.
But surgery is often a last resort.
So it's a tough condition to deal with.
It can be.
Now let's talk about another condition affecting the mouth. Leukoplakia.
Leukoplakia.
What is that?
Leukoplakia shows up as white patches on the mucous membranes of the mouth.
So like those white patches that can sometimes form on the tongue?
Yes, it can occur on the tongue, but also on the inside of the cheeks, the gums, the floor of the mouth.
Okay. And what's concerning is that leukoplakia can sometimes be a precursor to oral cancer.
That's right, a precursor to oral cancer.
So not all leukoplakia patches are cancerous.
Not all.
But some have a higher risk of turning into cancer than others.
Exactly.
Our sources really emphasize getting those white patches checked out by a healthcare professional. What kind of tests are done to determine if leukoplakia is cancerous or not?
A biopsy is essential. A small sample of the tissue is taken and examined under a microscope to look for cancer cells. This helps to determine the type of leukoplakia and guide treatment.
Okay, that makes sense. Now let's move on to the anatomy of the nasopharynx.
The nasopharynx.
This is the upper part of the throat, behind the nose.
Behind the nose.
And it seems like a busy intersection for both air and lymphoid tissues.
It is. The nasopharynx serves as a passageway for the air we breathe.
Right.
But it also houses important lymphoid tissues like the adenoids and the pharyngeal tonsils,
Right.
which play a big role in our immune system's defense against infections.
Speaking of adenoids, our sources bring up adenoid hypertrophy.
Adenoid hypertrophy.
which is the enlargement of the adenoids. And this is particularly common in childhood.
Very common in childhood.
So what problems can this cause?
Well, when those adenoids get enlarged, they can partially block the nasal passages,
Okay.
makes it difficult for a child to breathe through their nose. This often leads to mouth breathing, snoring, and in some cases even sleep apnea.
Sleep apnea, wow.
And enlarged adenoids can also contribute to those recurring ear infections.
Oh, how so?
They can block the eustachian tubes, the tubes that connect the middle ear to the back of the throat.
So it's like a domino effect.
That is.
Enlarged adenoids can trigger a whole chain of problems. How is adenoid hypertrophy typically managed?
It depends on the severity of the symptoms.
Okay.
In mild cases, watchful waiting might be all that's needed, especially since those adenoids tend to shrink as children get older. But if the symptoms are causing significant problems like persistent mouth breathing, sleep apnea, or those recurring ear infections, then an adenoidectomy might be recommended.
Okay, an adenoidectomy is the surgical removal of the adenoids.
Exactly. It's a fairly common procedure and can often significantly improve breathing, reduce snoring, and those ear infections. Now, let's move on to a more serious condition that affects the nasopharynx. Nasopharyngeal angiofibroma.
Nasopharyngeal angiofibroma. That one sounds a bit more complex.
It is more complex. It's a benign tumor, so it's not cancerous, but it's locally aggressive.
Okay.
It tends to grow and invade nearby structures.
And it almost exclusively occurs in adolescent males.
Almost exclusively.
Wow, that's interesting. Our sources describe this tumor as having a rich blood supply and a tendency to bleed profusely, which sounds like it could make treatment challenging.
You're right, it does. Surgery is the main treatment, but it can be a complex procedure because of that vascularity.
Okay.
Often, something called preoperative embolization is done. It reduces blood flow to the tumor, making surgery safer.
Okay. Less likely to cause excessive bleeding. So it's like cutting off the fuel supply to the tumor before you try to remove it.
Exactly. In some cases, radiation therapy might also be used, either to shrink the tumor before surgery or as an alternative to surgery in certain situations.
It's amazing how medical science has developed ways to manage these really complex and challenging conditions.
It is amazing. Now, let's move down a bit to the tonsils.
The tonsils.
Let's talk about acute tonsillitis, an infection we've probably all experienced at some point.
Acute tonsillitis, the classic sore throat.
Yes, an infection of the tonsils, those two oval-shaped pads of tissue at the back of the throat. It's usually caused by a virus, but it can also be caused by bacteria.
Right, specifically Streptococcus pyogenes, the bacteria responsible for strep throat.
Exactly.
So when it comes to treatment, antibiotics are often used for bacterial tonsillitis, but not for viral tonsillitis.
That's right. Antibiotics work against bacteria, but not viruses.
Right.
So if it's viral, the body will fight it off on its own. Things like rest, fluids, pain relievers, that's the best approach for viral tonsillitis. But if it's caused by strep bacteria, then antibiotics are essential to prevent complications.
What kind of complications can arise if strep throat isn't treated?
Well, one is rheumatic fever. It can affect the heart, the joints, even the brain.
Wow, that's serious. So if you think you have strep throat, you need to see a doctor, get tested.
Absolutely.
Now let's talk about a potential complication of tonsillitis. Peritonsillar abscess, also known as quinsy. What is that?
A peritonsillar abscess is a collection of pus that forms around the tonsil.
Okay.
It's usually a result of a bacterial infection.
And our sources describe it as causing intense pain, difficulty swallowing, and even a muffled voice. They call it a hot potato voice.
A hot potato voice. That's a good way to describe it.
Yeah, it's muffled and strained because of the swelling. It can be very uncomfortable.
It can be. Treatment is usually needed to drain the abscess and clear up the infection.
So if you're having trouble swallowing or your voice sounds muffled, it's time to see a doctor.
Yes, it is.
Now, our sources also mentioned that recurrent tonsillitis can be more than just a nuisance. It can actually contribute to other health problems.
You're right. Recurring tonsillitis can lead to sleep apnea, where breathing repeatedly stops and starts during sleep.
Right.
This happens because the enlarged tonsils can obstruct the airway.
Makes sense.
It can also make swallowing difficult and even contribute to heart valve problems in rare cases.
Wow, those are some surprising consequences. It's a reminder that those seemingly minor infections can sometimes have far-reaching effects.
They can.
So, when is a tonsillectomy, the surgical removal of the tonsils, recommended?
Tonsillectomy is usually reserved for cases where the tonsillitis is recurring and causing significant problems, or if there's a concern about obstructive sleep apnea. It's a common procedure and can often significantly improve symptoms.
Okay. Now let's move on to a serious infection that can affect the space under the jaw. Submandibular space infection, also known as Ludwig's angina.
Ludwig's angina,
Yeah.
it's a rapidly spreading infection, involves the floor of the mouth and the tissues under the jaw. It's often caused by a dental infection that spreads.
Our sources describe this condition as causing significant swelling, pain, and even potentially compromising the airway.
It can be very serious.
Mm.
The swelling can push the tongue upward and backward, making it hard to breathe.
So it's a race against time to get the infection under control.
It is.
What's the typical treatment for Ludwig's angina?
Intravenous antibiotics are crucial
Okay.
to fight off the infection.
Okay.
And in some cases, surgery might be needed to drain the infection and relieve the pressure.
Okay, now let's talk about the role of lymphoid tissue in the pharynx.
The pharynx, right?
That's the part of the throat behind the mouth and nasal cavity.
Exactly.
Our sources describe lymphoid tissue as our immune system's frontline defense against inhaled and ingested pathogens.
That's a great way to describe it. Lymphoid tissues are packed with immune cells. They're constantly on the lookout for those invaders. And the tonsils and adenoids, which we've already talked about, are key components of this system.
Right. And our sources introduce something called Waldeyer's ring. It sounds a bit ominous, but it's actually a collection of lymphoid tissues that encircle the entrance to the throat.
Waldeyer's ring, it's like a protective circle of lymphoid tissue
Okay.
made up of the tonsils, adenoids, and other lymphoid structures in the back of the throat.
Okay.
It's a first line of defense.
Okay, so it catches pathogens that try to enter the body through the nose or mouth.
Think of it as a strategic defense perimeter,
I like that.
guarding against those microscopic invaders.
Okay, from Waldeyer's ring, let's move on to a serious infection that affects the parapharyngeal space.
The parapharyngeal space.
This is located deep in the neck, and the name alone sounds intimidating.
It can be a serious infection, a parapharyngeal abscess. It's a collection of pus that forms in the parapharyngeal space. It's located next to the pharynx, the part of the throat connecting the nasal cavity and mouth to the esophagus and larynx. It's a relatively rare condition,
Okay.
but it can be serious because it's so close to those vital structures in the neck.
I'm seeing in our sources that it's surrounded by important blood vessels and nerves. So an infection in this area could have far-reaching consequences.
You're right. If it's left untreated, it can spread to the surrounding tissues and cause complications like airway obstruction, sepsis even spread to the brain.
That sounds really dangerous. What are the typical signs and symptoms of a parapharyngeal abscess?
Well, the classic symptoms are severe sore throat, difficulty swallowing, pain when you turn your head, and swelling in the neck, often with fever and chills.
So it sounds like you wouldn't want to wait to see a doctor if you experience those symptoms.
You wouldn't.
What's the typical treatment approach?
Treatment usually involves intravenous antibiotics to fight off that infection,
Okay.
and often surgery is needed to drain the abscess.
Okay.
It's serious, but with prompt treatment, most people recover fully.
That's good to hear. Okay, from parapharyngeal abscess, let's move on to another condition affecting the throat. Pharyngeal pouch.
Also known as Zenker's diverticulum.
Zenker's diverticulum. Okay, what is that?
It's an outpouching of the wall of the esophagus,
Okay.
the tube that carries food from the mouth to the stomach.
Right?
It usually forms just above the upper esophageal sphincter, the muscular ring that controls the opening to the esophagus.
So there's like a little pouch or pocket forming in the throat.
Exactly.
What causes that to happen?
Well, we think it develops because of weakness in the muscle wall of the esophagus.
Okay.
This allows a portion of the lining to bulge outward,
Okay.
and as the pouch grows, it can trap food.
Oh, I see. And that leads to symptoms.
Yes, very symptomatic.
Like what?
Well, our sources describe difficulty swallowing, regurgitation of food, even a gurgling sound when swallowing.
That doesn't sound very pleasant.
It can be quite bothersome. And in some cases, it can even lead to aspiration. That's when food or liquid enters the airway.
Okay. So how is Zenker's diverticulum typically managed?
It depends.
Okay.
The size of the diverticulum, the severity of the symptoms.
Okay.
In mild cases, watchful waiting, along with some dietary changes to make swallowing easier, might be all that's needed.
Okay.
But if those symptoms are really bothering someone, or if there's a risk of complications, then surgery might be recommended.
And what does surgery for this condition involve?
There are different approaches,
Okay.
but the goal is either to remove the diverticulum completely or to cut the muscle that's causing the problem,
Yeah.
allowing that pouch to open up and drain properly.
Right.
It's often done using minimally invasive techniques these days, which can really shorten that recovery time.
That's good. Now let's talk about a serious bacterial infection that can affect the throat. Faucial diphtheria.
Faucial diphtheria.
I know we have vaccines for diphtheria now, but it's still important to be aware of.
You're absolutely right. It's highly contagious, potentially life-threatening,
Okay.
caused by a bacterium called Corynebacterium diphtheria.
And what does it look like?
It's characterized by a thick, grayish-white membrane that forms over the tonsils and the throat.
Okay.
It can obstruct the airway, and it produces toxins that can damage the heart, nerves, and kidneys.
Wow, so very serious.
It is.
And our sources emphasize the importance of vaccination to prevent diphtheria, of course. But what about treatment for someone who's already infected?
Treatment involves two key things: antitoxin and antibiotics.
Okay, so what do those do?
The antitoxin neutralizes the toxins produced by the bacteria,
Okay.
and the antibiotics kill the bacteria themselves.
So it's a two-pronged attack to fight off the infection.
Exactly. And prompt treatment is crucial to prevent those serious complications. Fortunately, diphtheria is now rare in countries with widespread vaccination programs, but it serves as a reminder of the importance of vaccines in protecting public health.
Absolutely. Okay, let's move on to a condition that affects the larynx.
The larynx, also known as the voice box, laryngeal cancer.
Laryngeal cancer.
Okay, so this is a type of cancer that starts in the larynx.
The larynx. That's the part of the throat that houses those vocal cords and is responsible for producing our voice.
Exactly.
And I'm seeing in our sources that smoking and alcohol use are major risk factors.
They are. Smoking is the single biggest risk factor for laryngeal cancer.
Wow.
And the risk goes up significantly with the number of cigarettes smoked per day and how long someone has been smoking. Alcohol use also increases the risk, and that combination, smoking and heavy drinking, is particularly dangerous.
So what are the common signs and symptoms of laryngeal cancer that people should be aware of?
Often, the first sign is hoarseness,
Okay.
and it usually persists for more than a couple of weeks.
Okay, so not just a temporary thing.
Right. Other symptoms can include a persistent cough, difficulty swallowing, pain in the throat or ear, and even unexplained weight loss.
Okay, so it sounds like any persistent hoarseness or changes in voice quality should be checked out by a doctor, especially if someone has a history of smoking or drinking.
Absolutely.
How is laryngeal cancer typically diagnosed?
Laryngoscopy is the primary tool.
Okay, and remind me, what's a laryngoscopy again?
It involves using a thin, flexible tube with a light and camera on the end
Okay.
to visualize the larynx and look for any abnormalities. If we see something suspicious, a biopsy is usually taken to examine those cells under a microscope and confirm the diagnosis.
Okay, that makes sense. Now let's talk about a surgical procedure that involves creating an opening in the neck into the tracheostomy.
Tracheostomy.
Yeah, the windpipe. This sounds like a serious procedure.
It is.
So when is it typically performed?
Well, for a number of reasons.
Okay.
Often in emergency situations when someone's airway is blocked,
Right.
or if they need long-term help breathing, mechanical ventilation. It can also be part of certain surgeries on the head or neck.
So essentially you're creating a bypass for air to get into the lungs when the usual route is blocked.
You got it. The procedure involves making an incision in the neck and creating an opening into the trachea. Then a tube, called a tracheostomy tube, is inserted through the opening.
Okay, so what kind of care is needed after a tracheostomy?
Tracheostomy care is crucial to prevent complications.
Okay.
The tube needs to be cleaned regularly, suctioned to keep it free of secretions. Individuals with the tracheostomy might also need to learn new ways to speak, often with special valves or devices.
It sounds like a life-changing procedure,
It can be.
both in terms of the immediate medical needs and the adjustments someone might need to make in the long term. Now let's talk about stridor,
Stridor.
that high-pitched sound during breathing, which indicates a narrowing of the airway.
Exactly.
So what are some common causes of stridor?
Stridor can be caused by many things.
Okay.
Relatively minor things like croup,
Okay.
which is common in young children.
Right.
More serious problems like foreign body aspiration, where something gets stuck in the airway,
Okay.
or even structural abnormalities of the larynx or trachea.
Right. So the key is to figure out what's causing that airway narrowing.
And that's the key. Figure out the cause and then provide the appropriate treatment.
Okay. And the urgency of evaluation and treatment really depends on how severe the stridor is and the underlying cause, right?
Exactly. If someone is having a really hard time breathing, it's an emergency. Needs immediate attention.
Absolutely. Now let's talk about hoarseness, that change in voice quality that can be a symptom of various laryngeal problems.
Hoarseness. It's essentially any change in your voice, raspy, breathy, strained, or even complete loss of voice. It's a common symptom, and it has many different causes.
And our sources emphasize the importance of laryngoscopy to get a good look at the vocal cords and figure out what's causing the hoarseness.
Laryngoscopy is key, Lets us directly see what's happening with the vocal cords. We can identify problems like vocal cord nodules, polyps, inflammation, or even paralysis.
Okay, let's talk about one of those common causes of hoarseness, vocal cord nodules.
Vocal cord nodules, they're callus-like growths that develop on the vocal cords, usually a result of overuse or misuse of the voice.
So people who use their voices a lot, singers, teachers, or people who just tend to talk loudly, are they more prone to developing these nodules?
They are. They put a lot of strain on those vocal cords. Think of it like rubbing your hands together over and over. You eventually get calluses.
Right.
Same idea with vocal cord nodules. That repeated friction and irritation can lead to the formation of these callus-like growths.
Okay, that's a great analogy. And our sources highlight the importance of voice therapy and behavioral modifications to address these vocal cord nodules.
Yes, voice therapy is all about retraining the voice,
Okay.
developing healthy habits. It involves working with a speech-language pathologist. They can assess vocal technique, identify any harmful habits, and teach strategies to improve vocal health.
So it's like physical therapy, but for your voice.
Exactly.
Okay, and what about behavioral modifications? What kind of changes can people make?
Behavioral modifications are simple changes, but they can be really effective.
Okay, like what?
Proper hydration, avoiding vocal strain, even using amplification when speaking to large groups. All those things can make a big difference.
Okay, so it's about being mindful of how you use your voice and taking steps to protect it.
Exactly. Now, let's talk about foreign bodies in the airway.
Foreign bodies in the airway.
Yes, a potentially serious problem, especially for young children.
Okay.
Kids love to put things in their mouths,
They do?
and sometimes those objects could be coins, small toys, food can get lodged in the airway,
Right, blocking the airway.
blocking the airway, causing a partial or complete obstruction.
And our sources describe that classic scenario, a child putting something in their mouth, followed by a sudden cough or choking episode, then difficulty breathing.
It can be very scary, requires quick action.
It does.
If someone's choking and can't breathe, you need to administer basic life support measures like the Heimlich maneuver or back blows immediately while you call for help.
And in cases where the object can't be dislodged with those initial measures, our sources mention bronchoscopy as the procedure to remove it.
That's right, bronchoscopy. It involves inserting a thin, flexible tube with a camera on the end into the airway.
Okay.
Allows the doctor to see the object and remove it with special instruments.
Okay, let's talk about another condition that can affect the vocal cords. Vocal cord polyps.
Vocal cord polyps.
So how are those different from vocal cord nodules?
Well, both nodules and polyps are growths on the vocal cords, but polyps tend to be softer, more fluid-filled,
Okay.
almost like little blisters.
Yeah.
They often result from a single episode of vocal trauma, like yelling or screaming, or from chronic irritation like smoking or acid reflux.
Right. And similar to nodules, polyps can cause hoarseness and changes in voice quality.
Making it hard to speak or sing clearly.
Right. So what's the typical treatment for vocal cord polyps?
The treatment depends on the size and symptoms.
Okay.
In some cases, voice therapy and vocal rest might be enough for the polyp to shrink or resolve on its own. Okay. But if it's large or causing a lot of problems, then surgical removal might be necessary.
Okay, now let's delve into something we do all the time without even thinking about it. The physiology of speech.
Speech production is amazing.
It is.
It involves such a precise coordination of muscles, airflow, and those intricate movements of the structures in the mouth and throat.
It really is an intricate dance.
It is. The vocal cords vibrate to produce the sound.
Okay.
Air from the lungs powers those vibrations, and then the articulatory structures, the lips, tongue, palate, they shape those sounds into words.
It's incredible how all those elements work together to allow us to communicate.
I know, it is incredible.
Now, let's discuss a condition where the airway narrows, laryngotracheal stenosis.
Laryngotracheal stenosis.
Okay, what is that exactly?
It's a narrowing of the airway, either the larynx or the trachea. Makes it hard to breathe.
Okay.
It can be caused by a number of things. Trauma, prolonged intubation, infections, even congenital abnormalities.
So depending on the cause and severity, treatment can range from dilation to surgery, right?
Right. The goal is to open up that narrowed airway.
Right.
Improve breathing. Dilation uses special instruments to widen the narrowed area. Surgery might involve removing scar tissue or reconstructing the airway.
Sounds like it can be quite complex to manage.
It can be, often requires a team approach to address all the different aspects.
Okay, now let's talk about laryngocele, a condition involving an air-filled sac protruding from the larynx. What's a laryngocele?
A laryngocele is an abnormal dilation or herniation of the laryngeal saccule, a little pouch in the larynx, often described as an air-filled sac protruding from the larynx.
Okay, so what causes that to form?
They can be congenital present from birth or acquired, often due to increased pressure in the larynx.
So things like playing wind instruments or chronic coughing, things that put stress on those laryngeal structures, those could contribute to it.
They could.
Okay. And what are the symptoms of a laryngocele?
Well, the symptoms depend on the size and location, really. Small, asymptomatic ones might not need any treatment. Larger or symptomatic laryngoceles may need surgery to remove the sac and prevent complications.
Okay, so from laryngoceles, let's move on to a common viral infection in children, acute laryngotracheobronchitis, better known as croup.
Croup.
I remember that one.
Croup, a classic childhood illness.
It is.
Usually caused by a virus.
And it's pretty scary for both the kids and the parents because of that distinctive barking cough and stridor.
It is scary.
It is. So what's the best way to manage croup?
The good news is most cases are mild,
Okay.
and they resolve on their own in a few days with supportive care.
Okay, so keeping the child calm.
Keeping them calm, providing humidified air, sometimes medications to reduce the inflammation. But if they're having a really hard time breathing or showing signs of distress, medical attention is needed right away.
Okay, now let's talk about a more serious bacterial infection, epiglottitis.
Epiglottitis.
This one can affect the epiglottis, that little flap of tissue that covers the windpipe.
Exactly. Epiglottitis is a rare but potentially life-threatening infection. It can cause rapid swelling of the epiglottis, which can then block the airway.
Wow, that sounds terrifying. What are the signs and symptoms?
High fever, sore throat, drooling, difficulty breathing, and a muffled voice. Those are the classic signs.
And any suspicion of epiglottitis, it's an immediate trip to the emergency room. Right?
Absolutely. It's an emergency. The priority is to secure the airway, maybe by placing a breathing tube, and then administer antibiotics.
Okay, that sounds intense. Now let's move on from airway issues to problems with swallowing, which is known as dysphagia.
Dysphagia.
And this can have a lot of causes, right?
It can. Problems with the muscles involved in swallowing, structural abnormalities, neurological conditions that affect the nerves, even some medications.
I'm seeing in our sources that it's important to differentiate between oropharyngeal dysphagia, which involves difficulty initiating the swallow, and esophageal dysphagia, where food gets stuck further down.
That's an important distinction because it helps narrow down the possible causes.
Right. So oropharyngeal dysphagia often points to problems with the muscles or nerves in the mouth and throat, while esophageal dysphagia suggests problems in the esophagus itself.
Exactly.
And our sources list various diagnostic tools that can be used to pinpoint the cause. Things like barium swallow studies, endoscopy, motility studies. Can you give us a quick rundown of what each of those entails?
Sure. With a barium swallow study, the patient drinks a liquid containing barium, which shows up on x-rays. It lets us see how the liquid moves through the mouth, throat, and esophagus.
Okay.
Endoscopy involves inserting a thin, flexible tube with a camera into the esophagus to get a direct look.
Okay.
And motility studies measure the pressure and coordination of those swallowing muscles.
Okay, so those tests provide a pretty comprehensive look at the swallowing process.
They do. Now, let's talk about corrosive esophageal injury, which can occur when someone ingests caustic substances.
Corrosive esophageal injury. Okay.
This is a serious problem that occurs when someone swallows a caustic substance, like strong acids or alkalis often found in cleaners and industrial chemicals.
Right.
It can cause severe damage, leading to immediate issues like airway compromise, perforation,
Yeah.
and long-term risks like stricture formation.
That sounds really frightening.
Yeah.
So what should someone do if they've ingested a caustic substance?
Seek medical attention immediately.
Immediately.
Right away.
Call 911.
Call 911. Try to identify the substance that was swallowed and provide as much information as possible to the medical personnel. That quick action can be life-saving.
And our sources emphasize that treatment can range from stabilizing the person and managing the airway to emergency surgery if needed.
It can. And long-term follow-up is essential to watch for complications.
Okay. Now, For something less serious, but still unpleasant, something I think a lot of people have experienced, especially those who enjoy seafood, we're talking about swallowed fish bones.
Ah, the dreaded fishbone. Very common.
It is. What's a first step when you think you have a fish bone stuck in your throat?
First, try to determine if it's actually stuck.
Okay.
Sometimes the feeling can linger even after the bone has dislodged.
Okay, so you might not actually have a fish bone stuck.
Right, so a thorough exam is needed to confirm its presence and where it is.
And if the bone is stuck, what's the best way to remove it?
If it's visible and easy to reach, a doctor might be able to remove it with forceps.
Okay.
But if it's deeper or we can't see it clearly, then we might need endoscopy to remove it safely.
Endoscopy again.
Yeah.
It seems like a really valuable tool for visualizing and accessing those hard-to-reach areas.
It's a very valuable tool.
Now let's talk about a procedure that allows for a comprehensive look at the esophagus. Esophagoscopy.
Esophagoscopy.
So what is that?
Well, it uses a thin, flexible tube with a camera on the end to examine the lining of the esophagus.
Like taking a video tour of the esophagus.
Exactly.
So what are the reasons why this procedure might be done?
Lots of reasons, actually. It can help evaluate swallowing difficulties, investigate suspected tumors, remove foreign objects, even take biopsies.
Okay.
Lots of uses.
Okay, so a very versatile tool. Now let's talk about swallowing deglutition is the fancy term.
Deglutition.
It's something we do so many times a day without even thinking.
Swallowing is actually a complex process. It involves a very specific sequence of muscle contractions to move food from the mouth to the stomach.
Our sources break it down into three main phases: oral, pharyngeal, and esophageal.
3 phases.
Can you walk me through them?
Sure. The oral phase is voluntary.
Okay.
That's where we chew our food and use our tongue to push it back.
Okay.
The pharyngeal phase is involuntary. The food triggers reflexes that propel it through the pharynx.
Okay, and the pharynx is that part of the throat connecting the mouth to the esophagus.
Exactly. And finally, the esophageal phase.
Okay.
The food travels down the esophagus and into the stomach.
It's amazing how smoothly that sequence happens, usually without any conscious effort.
I know, it's amazing.
Now, our sources also discuss the esophageal sphincters, the muscular rings that regulate the flow of food.
Those sphincters, they're like gatekeepers. They make sure food moves in the right direction at the right time.
Okay, so tell me about them.
Well, the upper esophageal sphincter, or UES, prevents food from going into the airway.
Okay.
And the lower esophageal sphincter, or LES, prevents stomach acid from coming back up into the esophagus.
Okay, that's important. Now let's talk about a condition that affects the LES, achalasia.
Achalasia.
What's going on in that condition?
Achalasia is a rare condition. The LES fails to relax properly, makes it tough for food to pass from the esophagus into the stomach.
So the door's stuck shut.
Exactly, stuck shut.
And what are the symptoms of achalasia?
Difficulty swallowing, food coming back up, regurgitation, chest pain, even weight loss.
And those are all because of the food buildup in the esophagus.
Exactly.
It can't move into the stomach like it should.
Right.
Okay, so how's achalasia diagnosed and treated?
Well, diagnosis often involves a barium swallow study. We talked about that earlier.
Right.
And esophageal manometry, which measures the pressure and coordination of those esophageal muscles.
Okay, what about treatment?
The goal is to relax or widen the LES to help food pass into the stomach. We can try medications, minimally invasive procedures like balloon dilation, or, in severe cases, surgery to cut the muscle fibers of the LES.
Now, our sources mention a rare type of dysphagia called dysphagia lusoria.
Dysphagia lusoria.
Yeah, that one sounds interesting.
It's fascinating. It shows how anatomical variations can cause some pretty unexpected symptoms.
Okay, I'm intrigued. Tell me more.
It's this rare type of dysphagia difficulty swallowing.
Yeah.
It's caused by an abnormally positioned blood vessel that compresses the esophagus.
So instead of following its usual course, this blood vessel is pressing on the esophagus, making it harder for food to pass through.
Exactly.
Okay, so like a detour creating a bottleneck. And our sources mentioned this has an embryological basis, meaning it originates during fetal development. That's amazing.
It is. During development, those blood vessels are forming, rearranging.
Oh, good.
And sometimes a vessel might take an unusual route.
Okay.
In dysphagia lusoria, it's often the right subclavian artery, a major vessel branching off the aorta.
Wow, and that detour ends up compressing the esophagus.
Exactly.
So how do you manage dysphagia?
It depends on how severe the symptoms are.
Okay.
Mild cases might just need some dietary modifications and watchful waiting. But if the symptoms are severe or there's a worry about complications, we might consider surgery to reposition the blood vessel or widen the esophagus.
Okay, from those anatomical detours, let's move on to esophageal strictures.
Esophageal strictures.
Those are narrowings of the esophagus that make it hard to swallow.
Exactly, like a bottleneck in the esophagus.
What causes those to form?
Lots of things. One common cause is G-Zerder,
G-art. Okay, we'll get to that in a minute.
where stomach acid flows back up into the esophagus,
Okay.
damages the lining, leads to scarring and narrowing.
Okay. What else?
Corrosive injury from swallowing those caustic substances.
Right, we talked about that.
And radiation therapy, which is often used to treat cancers, can sometimes damage the esophagus and cause strictures.
Okay. And how are esophageal strictures typically treated?
The focus is on widening that narrowed area,
Okay.
improve swallowing. One common technique is dilation, where we use a special balloon or dilator to stretch the stricture. Sometimes medications can help reduce inflammation and promote healing. And in more complex cases, surgery might be needed to remove the stricture or rebuild the esophagus.
Okay, so lots of options depending on the situation.
Here are
Now let's tackle GERD, which we've mentioned a few times already.
GERD.
That's where stomach acid flows back up into the esophagus.
It's a common problem. Millions of people experience it.
They do.
Heartburn, regurgitation, chest pain. It can really affect quality of life.
So what causes GERD?
It's often related to the lower esophageal sphincter, the LES,
Right.
that muscular ring between the esophagus and the stomach.
Right, it acts as a valve.
If the LES weakens or relaxes too much, stomach acid can escape back up.
Makes sense.
Another contributing factor can be a hiatal hernia.
Hiatal hernia, okay.
That's where part of the stomach bulges up into the chest.
Okay. And what are some of the treatment options for GERD?
Well, lifestyle modifications are often the first step.
Okay, like what?
Losing weight, avoiding trigger foods, fatty foods, spicy foods, eating smaller meals more frequently, not eating close to bedtime.
So it's all about minimizing those chances of acid refluxing back up.
Exactly. And then we have medications.
Okay, what kind of medications?
Medications can help neutralize that stomach acid or reduce its production.
Okay.
We have antacids for quick relief and prescription medications like H2 blockers and proton pump inhibitors that last longer.
Okay,
And in severe cases, surgery might be considered.
okay. When would surgery be an option?
If those medications aren't working or there are concerns about complications, the most common procedure is fundoplication. The upper part of the stomach is wrapped around the LES to strengthen it and prevent reflux.
Okay, now let's discuss a condition that's less serious than GERD, but can still be bothersome. Globus pharyngeus.
Globus pharyngeus.
Yeah, that's the persistent feeling of having a lump or something stuck in your throat.
Even when there's nothing physically there.
I've definitely felt that before, especially when I'm stressed or anxious.
It's a common sensation, and it's usually not a sign of anything serious.
That's reassuring. But our sources do mention that if it persists or there are other symptoms, it's a good idea to see a healthcare provider to rule out any other underlying conditions.
Always better to be safe than sorry.
Well, I think that about wraps up our deep dive into the world of ENT conditions.
We covered a lot of ground.
We did. From the simplest ear infection to complex surgical procedures and everything in between. We've talked about causes, symptoms, and treatment approaches for a wide range of conditions, and I hope everyone listening now feels more knowledgeable and empowered to advocate for their own ear, nose, throat, and even esophageal health.
Absolutely. Knowledge is power when it comes to health, and I hope our discussion has inspired everyone to learn more and take an active role in their own well-being.